exciting speakers. So we've got Lucy Buxton from the NCL Maternal Medicines Network. We've got Hannah Logan from the smoking cessation team, and Teo going to give us an update on the cervical screening system changes. So quite a lot to get through. I'd wanted to kick off with a bit of a CPD update as well. So we'll start there. But firstly, just wanted to wish everyone a happy International Nurses Day for last Sunday, 12th of May, to all of you. Right, so a few CPD updates. Obviously, you would have all been receiving the newsletters, and this information is all on the newsletter. So if you miss anything, please go back to the newsletter. Barbara's just informed me that this meeting's been recorded as well, so you can always catch up on that. So just wanted to let everyone know about a few expressions of interest that will be flying around that you may hear about. And if you do get engaged in any of these conversations and you want to learn more, you can get in touch with us. So firstly, it's the Student Nursing Associate expression of interest. So for the deadline for that is the 29th of May, and it's an opportunity to develop any existing staff who want to go into the role of a student nursing associate, and an opportunity to employ staff as well. Second one, again, we're very much awaiting confirmation from NHSE for future funding for this, but you may start hearing conversations about expression of an interest for the GPN trainee program, normally a September cohort. So you may have well had some GPN trainees in your practice in the past, and your employers, practice managers, PCN CDs may start these conversations, and you may hear of them. So if you want information, if you're not sure what it involves, you can always get in touch with us. There is a free lunchtime webinar on the 23rd of May. Information about this will be circulated in this week's newsletter, but the webinar is essentially about how group clinics can support the development of nursing workforce. On top of that, I've got a few more updates. We've got the 2-day fundamental immunizations on the 28th and 29th of May. So these are for nursing team members new to immunizations. And obviously, if you have any allied health professionals in your team that may be looking for CPD offers and aren't sure, they can always get in touch with us as well, and we'll let them know if they can attend any, or if any suitable training coming up. We've got the travel health update, the introduction to travel health as well. There's immunizations update as well, June 18th of June, there's an AM and a PM session, and for the 20th of June there's an afternoon session for that. And lastly, there's some dementia training coming up on the 13th of June, again lunchtime event, and this will be quite an informative workshop. Actually, it's kind of looking at dementia, types of dementia, differential diagnosis, management, and how to support informal carers as well. So that's a little bit of a CPD update. Again, if you've missed anything, Barbara's thanks. You put it up in the chat. Thanks, Barbs. So lovely. Lucy, I've seen you on call. I saw you earlier. Lucy Buxton's here with us.
Hello.
There you are. Hi there. Hi. Welcome, Lucy. I'll let you
much.
introduce yourself, but I'll just let everyone know that you're here from the NCL Maternal Medicines Network, and you're going to talk about introduction to clinical network and caring for pregnant women. Lovely.
Yeah. Real, thank you so much. I'm just going to load my slides at the same time as me chatting away. I apologise if I cough. I've got this horrible cough that everybody's got at the moment that just seems to be doing the rounds. So yeah, I apologise in advance. Like I said, my name's Lucy. I'm the lead midwife for the North Central London Maternal Medicine Network, and I'm here just to give you a little bit of an overview as to what is the network, what do we do, and my slides are all working perfectly, and of course they're not now. Let me just put them into slideshow mode. What do we do? Who do we look after? And actually, what am I here to offer for you? And really, realistically, so just to give a little bit of context as to where kind of maternal medicine networks have come from. So this is the Embrace report. This is our overview of maternal deaths over the last probably 20 years. And so the orange line detects the total number of maternal deaths, and the blue and the purple lines denote those that are either direct deaths or indirect deaths. What as a maternal medicine network, obviously what we're particularly interested in is women with obviously complex medical needs, and they would fall under our indirect deaths. So these are deaths that are resulted from a pre-existing disease. And as you can see, unfortunately, we're not making a huge amount of progress, with reducing the number of deaths. Thankfully, they are still small, but however, we need to be doing more to really make a difference. When we look at kind of the breakdown as to where these deaths, what they attribute to, obviously, given the last few years, COVID makes up a large proportion, and the biggest reason for deaths over the last few years. But we're taking those aside. We are really looking at our women with pre-existing cardiac disease, blood clots, mental health. So for us, we had to really look at our services and how are we able to kind of make sure that we are making a difference. The other thing that's really pertinent and that you'll see hugely within the news is looking at kind of looking at our inequalities within our maternal mortality, and how does that attribute and what difference can we make. It's well publicised that obviously women from an ethnic minority background are much more likely to die in pregnancy, and alongside those that are living in the most deprived areas. So we really have to be looking at what we can do. So NHS England, and there was another number of national reports came out, and looked at actually how are we able to provide equitable care for all women with acute and chronic medical problems. And so we've had to really kind of, what they've done is they've implemented what we'll go on to kind of talk about, these services, about making sure that women have access to the right people at the right time and are all able to get the same standard of care no matter where they live. So what they did, they created these networks. And these were kind of looking at how we can link all these substantive services, but also looking at how do we create a pathway for women to be able to access specialists. Because we know that if a woman, say if we're booking a patient who books at, say, Barnet, may not have access to that same specialist as a woman who books at UCLH. So we had to look at how we could create that kind of pathway so that woman is able to access the right people to make sure she gets the right care. So what that looks like, and the huge amount of kind of people that surround these women during pregnancy, is never ending, and definitely include yourself, because when we think about kind of a woman, her journey will always start well before pregnancy, and the huge amount of expertise that she's received. Obviously, she comes into a maternity service, and actually we have a very small snapshot of time with these women to try and control their disease, make it kind of fit for pregnancy, before obviously shipping them back out into maternity and back into the care of their specialists, their general practitioners. So really looking at how we do that. We risk stratify all of our women when they are booked with us, and dependent on their condition and the severity of their condition depends on where we kind of dictate their care to be. So as a little bit of an example, we kind of create all of the different systems and categorize the women into a category A, B, and C. Our women who have a category C condition, we would expect for them to be cared for at the maternal medicine centre, so that would be UCLH, and then your category Bs would be cared for maybe with a little bit of input from the centre, but mainly at their local hospital. And then your category As are actually relatively low risk in terms of disease and are able to be cared for kind of at any kind of DGH, with a little bit of input from the specialist services. We're, in terms of kind of looking at kind of networks kind of overall, so there are 17 networks across the country. Within London there are 5, and obviously we're part of North Central London, which thankfully covers the kind of the same region and takes up kind of Camden, Islington, Haringey, Barnet and Enfield, and all of the retrospective hospitals obviously that encompass that. So yeah, I kind of said this already. So UCLH is the maternal medicine centre. So this is where kind of obviously, you know, as the tertiary referral centre, it's where all of the main specialists are. However, we are really reliant upon some of the amazing services that are run out of some of the other areas, such as Whittington has a great kind of haematology service, the Royal Free obviously with their renal and liver services, and obviously we can't provide everything within North Central London. You know, we do have to look over to kind of East London when we think about some of our cardiac cases, or even going kind of south of the river when we're thinking about some of our neurological conditions and how we care for them. So it's very transient. I think the really big push for us though is that we're trying to develop a service where we can care for these women at the hospital that they want to be at and within their local community. We don't want to really bring everybody to UCLH if we really don't have to. So I can't really stress enough that actually this is a real minority of women, and as much as we can, we as the service and the specialists are trying to go out to the other hospitals as much as possible. And we are fortunate that geographically we are able to do that. Other networks are not as privileged. When I talk a little bit about kind of the team and who we are, we kind of have our senior leadership team, which includes myself. I have 2 consultant obstetric physicians. Obstetric physicians are a pretty new breed of doctor that have really only been developed over the last probably 5-10 years. So they're a physician by background with a specialist, so whether it's a acute medic or a renal or cardiac, but then choose to develop into an obstetric physician by training to look after women with medical complexities in pregnancy, because we know that actually, you know, the majority of doctors who come across a pregnant woman can be quite fearful and might not actually know what is safe and what is, you know, how to care for these women. So they're a really good breed. There's only probably in the country about 30, 35. So yeah, they're starting to kind of come through. And then we have our obstetric consultant, Miss Lambo, as part of our senior team. However, it's not just us. We have a huge range of us. Obstetricians, specialists and specialist midwives. I think as midwives, when we're looking at the population, when we're looking at kind of what our midwifery population looks like now, only 15% of midwives are actually dual trained as a nurse and a midwife. So for us, and I mean for me as kind of the lead midwife of the service, we can't really be reliant upon midwives having actually the same in-depth knowledge as yourselves as to women with these medical conditions. Yes, they're great with birth and how to look after you know, a woman giving birth, but actually it's really changing what we look like as a midwifery population, because we have to be adapting to the demographic of women that are now being presented to our service. So what are we looking like, and what's kind of our aims really of the network, and what do we want to do? So exactly like I've kind of talked about all the way through, thinking about how do we provide equity of service. Just because a woman books, you know, chooses to book her pregnancy at North Middlesex doesn't mean that she shouldn't receive the same standard of care. Making sure that we're personalising all of that care towards her, and we're really bringing in a multi-agency approach to be able to care for these women. And again, kind of standardizing, making sure we are engaging with other services. So what is out there, actually, what can we do to learn from other specialties? I think in maternity, I think we can shoot ourselves in the foot a little bit and work quite in silo. And when actually we have these patients for a really short amount of time relatively. So what can we do by reaching out to others and actually listening to the women, listening to their families, what would work better for them? We're really looking at kind of our pathways of working with other specialties, but also the other end of the spectrum of when a woman presents to accident and emergency or ED, how do we capture these women? Yeah, and looking at how we can really kind of broaden ourselves as a network. The referral pathways you can are all kind of we're just about, we're all live on the GP website, on the NCL GP website, as to how you can refer to us. And this can be for kind of for anybody, you know, if you've got a, you know, a query or a woman that you think actually needs a bit of, it is really complex and needs a good bit of input. We also have started to look at doing pre-pregnancy counselling, which I'll come on a little bit on my next slide. But this is kind of, yeah, open for everybody, and I'll provide more more details of this at the end. So some of our biggest bits of work that we're doing at the moment since we kind of went live. So pre-pregnancy, the evidence shows that if a woman with a chronic medical condition receives tailored, personalised pre-pregnancy counselling, she is much more likely to do better in the long term. Our issue is funding, as it always is in the NHS. You know, at the moment, it's in this really grey matter where it sits between gynecology and obstetrics. We're a network and a service that sits amongst both, because we will see women from who are pregnant from, you know, conception to all the way kind of 6 weeks, 6 weeks and more postnatal. So what we started doing is doing some pilot group sessions for preconception counselling. So we've done one recently with our IBD colleagues, and then we've also done one with epilepsy, and they've done really well. I think what we're slightly worried about, though, is that these are women who are really engaged with their service and really understand their disease, when actually what we want is those women who probably aren't as who don't probably engage as well, because we know that those women are much more likely to have a worse outcome. So that's our challenge as to how we're going to be able to engage them next. What we're doing kind of in terms of kind of pregnancy, we're looking at kind of, again, how we work with our other colleagues, so strengthening some of our MDTs and being able to bring those people together. And then postnatally, because we know actually that is the most riskiest time for these women, and actually where as maternity is most underserved, we've started a dedicated postnatal clinic. So actually before they are discharged, so we try and see some of these women at kind of the 4 to 5 week postnatal mark before they completely fall out of maternity care. Gets around the funding issue. So we can then set them up with a package of care, making sure that they've engaged with the relevant community services, with the GPs, with the health visitors, to make sure that actually they're set up well before they are released, if you like, completely from maternity care, to make sure that they're okay and they know who to contact. And also, as part of that consultation, we do a little bit of pre-pregnancy counselling in anticipation of their next pregnancy. So a little bit of a one-stop shop. We're looking at the kind of the acute pathways. So when women present to accident and emergency, who do they see, and trying to do some education with our colleagues in ED about actually management of a pregnant woman. The majority, one of our biggest kind of take homes is that actually pregnant women should be treated much like the rest of the population and shouldn't really be denied any care. We've seen from many investigations and many reports that actually it's when pregnant women are treated differently that's when we see the worst outcomes. So we're doing a lot of work around that. And just to finish up, because I'm very conscious of time, some of the other kind of projects and future directions of what we want to do. We are reviewing all of the maternal deaths from the last 5 years within North Central London, to really look at actually what is the sharing and learning of those, and actually who have they been shared with, and what can we do to better standardise that. Looking at our women similarly who've been admitted to ITU, we're working on a network website, preconception, postnatal, and then education is the big bit, I suppose, that and especially relevant for kind of this forum. We are very happy to come out into any forum, if you like, and to do some kind of educational pieces about caring for pregnant women, and actually what are some of the red flags, what do we worry about, actually what is normal, what would you anticipate to see, and really trying to kind of engage with other services out there. I think because you guys are a huge resource, you're the people who kind of care for these women the majority of the time outside of those 9 months, and so I really want to feel that we are a resource to you, and want to be able to if we can help in any way, or if there's anything further that we can do, then we're here for you. And the final slide, obviously, just some of our contact details. I'll happily share these slides so they can be kind of cascaded out, in terms of kind of how to signpost, how to contact us, and who's available. But thank you very much. I really appreciate your time and the opportunity to speak to you all.
Thank you so much, Lucy. And you know, it's very much been in the news recently as well. So kind of great to have you here today to tell us about the great work and the role of the network. And it was lovely and refreshing to hear about, you know, you're really looking at sort of keeping care close to home, because I've heard of women that, you know, want to be booked into hospitals quite far away from home, really. And it's all the logistics that go with that. So thank you. Any questions for Lucy? Are you going to stay with us, Lucy? I wonder if anyone's sort of have any questions, they can post them in the chat later, or I can always send the question. If there are any questions, I can send them to you by email and you can get back to us.
Yeah, I'm gonna have to drop off, unfortunately.
Fine,
but yeah, any please feel free to contact me. But yeah, if there's any kind of like such as educational asks or anything that you think that would be helpful, please don't hesitate to reach out, because I'm more than happy to provide what we can.
Thanks so much for your time today, Lucy. Thanks for joining us.
Thank you so much.
Okay, take care. That was great. Hannah, I see you're on call as well. Thank you so much for coming. So Hannah's a public health consultant and from the smoking cessation team. So thank you for joining us and to give us an update.
Thank you. Can you see my notes as well as the screen?
No, just your slideshow.
You can just see the screen. That's good. Okay. So I'm actually not from the smoking cessation team. You had asked a colleague originally to present. So I'm a public health consultant, and I'm a split position between the 5 public health teams in the local authorities and also North Central London ICB. So I work across the kind of 6 organisations, and my portfolio covers the kind of prevention agenda. So tobacco, healthy weights and alcohol. And so I came today to sort of just do a general update about what's going on across North Central London around tobacco, and then also sort of what the role is, or what we would like to ask of you, I suppose. There is going to be some audience participation, so please don't feel shy and do come in on it. So why do we need prevention? So in North Central London, nearly a quarter of the deaths over a 5-year period in people under the age of 75 are from causes that could be prevented. So through interventions such as smoking cessation, diet, activity, reducing alcohol, we can actually reduce the disparities in health inequalities. So prevention is really important, and it's really difficult in our day job to find the time to do prevention. But quite often it's one of the most cost-effective and positive things we can do to improve clinical outcomes. So this is just from the Global Burden of Disease study, and it shows that basically over time not much has changed with regards to the impact that tobacco has on the premature death and disability. So in the last 15 years, tobacco has remained the #1 cause of morbidity and mortality. And I'll come on to the next slide about the different groups that are actually inadvertently impacted by tobacco. I think there's a kind of image out there that we've tackled tobacco. Obviously, obesity is like a huge issue now, but we've still got quite a long way to go, although we have made good progress. So does anyone want to make a guess at what they think the current smoking prevalence is in North Central London at the moment? Just have a stab, just unmute yourself and shout a number out. What percentage?
1 in 15.
1 in 15, okay. So that's what about, what is it, the percentage? 6%? 7%?
I was actually going to go for 15%.
15%? Okay, so the actual smoking prevalence in North Central London at the minute is around 12%. So that's around 127,000 people in North Central London who still smoke. Can anyone have a guess at what percentage they think people with serious mental illness, what the percentage of smokers, what the percentage of people with serious mental illness, what proportion smoke? So if it's about 12% in the general population, for those with serious mental illness, what percentage do you think it is?
About 40.
Perfect, yes. So around 40%. So that's a huge difference in prevalence, and that's where the sort of inequality comes in as well. And then it's about 30% in routine and manual occupations. So although smoking prevalence used to be around 25%, and with all the stuff that we've done over the last 20 years, it's dropped. There's still key groups in the population, and actually just coming on from the presentation that we just saw, we have about 5% of mothers still smoking at the time of delivering their babies. And actually supporting a woman to stop smoking during pregnancy is one of the biggest impact that you can have on not only her, but her child, not only her child, but also her sort of future health. Smoking pregnancies causes a lot of adverse outcomes, stillbirth, cleft lip, etc., low birth weight. So people in the more deprived groups are 5 times more likely to smoke, and it has a huge impact on the healthcare and social care. The fire systems, it's in the billions that it costs North Central London across the system. So it's a huge issue. They're more likely to be admitted to hospital, longer length of stay, more likely to be readmitted. So there are different prevention strategies that we can do to try and help people. So we have primary prevention, which is about stopping people smoking in the first place. And we have secondary prevention, which is about supporting someone to quit once they've started smoking. So I just want you to take 10 seconds to just have a little think about what primary prevention you can think of that is national or local, and that what else you might know of. And so on the next slide, I'm going to ask you just to shout out some ideas. Well, actually, no, on this slide, because the next slide's got the answers. So can anyone have a think of some national kind of policies or things that have been done that might be trying to prevent people to stop people smoking in the first place?
Someone's put tax in the chat box. Casey.
Yeah. So increasing the cost of cigarettes. So I think they used to be about £3 or £4, and now I don't know. I think they're about £15 or something. So there's a tax. What came in Ireland first, and then it came in here about, I don't know, maybe 15 years ago.
Smoking indoors.
Yeah. So no smoking indoors. Anything else that you can think that's been done around cigarettes that might be trying to prevent people from smoking them? Think about the packaging.
So Barbara's put, sorry, go ahead.
I was going to say, someone put that on the chat.
Oh, I can't see the chat, sorry.
It was risks.
Yeah, so like putting those horrible pictures or the plain packaging and things. Okay, okay, anyone think of any kind of secondary prevention? So things about supporting people once they've started. Can anyone think of what might exist around that sort of secondary prevention? If anyone's putting stuff in chat, I can't see the chat, sorry. Right, I'll move on.
Someone's put Stoptober, providing free nicotine patches, changing the age we buy them, pictures on packets, not smoking in public, smoking ban indoors, and then photos on packaging, high cost, advertising. And then I was going to say, no, you can't smoke in a car with your child. I don't know if that's law yet or not.
Yeah, no, it is law. It is law. So yeah, so all of these things have been done over the last sort of 30 years nationally. All these like national days and the policies, and like you say, no smoking in cars. That's to protect children from secondhand smoke. So there's all these things that have been doing then, and then we do quite a lot locally. So there's like education in schools, and then locally commissioned stop smoking services. So just quickly was to go through. So we've got the ban of sale to cigarettes and under 18s. We've got ban on tobacco advertising, smoking ban in enclosed spaces. That was 2006. Smoke free in vehicles, increasing the cost of cigarettes. And then locally, we've got in-reach work in schools. There's law enforcement in your local boroughs because illicit tobacco is still a huge thing. And then we have the community sort of stop smoking services, which we'll come on to. So these are just some things. So we've got the packaging, the making it illegal to smoke inside, like you said, about non-smoking in the vehicle, and that's really about children and secondhand smoke. Working with schools for local campaigns, and then we've got these kind of national campaigns that you'll see, and then making every contact count, which is what I think the ask of all the kind of health professionals in our system. It's what our ask is that you have these conversations with people. So there's a lot of evidence, probably one of the most evidence-based interventions that we have around smoking. So what works? So what works is that people are more likely to, 4 times more likely to quit with behavioural support and nicotine replacement therapy, although still about 60% of those who quit do it unaided. So we have licensed medication to support people, and we have behavioural support services in our boroughs. And all the evidence says that you are more likely to quit and sustain a quit if you go through that. There's also a lot of evidence around those teachable moments. So you as a health professional, if you are having a conversation with your patient, that they will trust your opinion and be more likely to engage in a quit attempt if you've actually had that conversation, rather than them just walking off the street and you know, just having seen an advert or something. So just a bit about what's going on in secondary care. So we had something come out in 2019 called the long-term plan, and this is really talking about what the NHS's role is around prevention and what the expectation is. And it has tobacco in there. And so what the NHS long-term plan says is that the NHS will make a considerable contribution to England being a smoke-free society by supporting people in contact with NHS services. And it's an evidence-based model that's came out of Canada and also Manchester. So the ask is that all people have, well, we're past 23, 24, but all people admitted to hospital will be offered NHS-funded tobacco treatment services. There's an adapted model for pregnant women and their partners, and that's moving the provision in-house, so it'll be part of their maternity care. And then they're trying to look at a specialist service for people with SMI and learning difficulties, because like I said, the smoking rates in those cohorts are way, way higher, and they need a kind of more flexible service. So I'm doing loads of work at the minute with our acute and mental health trusts and maternity services, training up staff within the secondary care to have these very brief advice conversations and be referring people into our community services. So this is just what exists at the moment. So Camden and Islington and Haringey have a commissioned out service, One New Haringey and then Breathe, which is in the bottom left-hand corner. So you can refer to these services. Barnet have a bit of a mixed model. They've got in-house advisors in the local authority. They also commission pharmacy and GPs to provide services. Enfield doesn't currently have a stop smoking service. However, part of the new smoke-free generation, which is the government's new pledge around tobacco, each borough has been given quite a large amount of money to develop services. So Enfield is in the process of procuring a commissioned out service. So there will be one. But we also have Stop Smoking London, which is a London-wide service. And there's sort of an app as well as talking to an advisor. And then you've got online resources and apps as well. If you have a Google, there's kind of various ones. So my colleague who leads on commissioning of Breathe, which is the Camden and Islington, was asked to do this originally and she couldn't, which is why I offered to come in. But there's a couple of slides about her service. So just to give you an idea, now, like I said, each borough's got slightly different. But if you're talking to a patient and they mention they smoke, and you can tell them what they can expect. So up to 12 weeks of behavioural support and nicotine replacement therapy. And it's eligible for anyone that lives, works, studies, or is registered with a GP in Islington and Camden, which I think is really amazing. You know, if we think about how many of the staff in our trusts that work here but don't live here, but they can get access, and it's self-referral as well. What they offer is behavioural support. So a stop smoking specialist will talk to the patient about what their motivations are to quit and about what there's a lot of misconceptions, I think, around smoking. And people don't necessarily understand that nicotine is the addictive substance that's put in a cigarette, and that nicotine itself is not actually harmful. It's addictive, but it's not actually harmful. And so actually going on to nicotine replacement therapies will mean that they'll stop smoking and stop breathing in those like thousands and thousands of toxic chemicals, but they'll still get the nicotine that they need through either a patch or a lozenge or whatever it is. So they will talk to the patient and explain what the kind of root of addiction is and how we can try and break these habits and what medication might be best for them. So there's various different nicotine replacement therapy products. We've got the patches, which can last for 16 or 24 hours. We have chewing gum, we have lozenges, we have inhalators, nasal spray. A lot of people who smoke say that it's just that habit of like hand to mouth kind of thing. And so some people really like those inhalators because they think they're still sort of using their hand and going to their mouth. And we just have to kind of explore with the patient what is going to suit them best. With pregnant women, we do triple therapy because their metabolism is so much faster that actually need more than one nicotine replacement therapy. But others, depending on the level of addiction, you would prescribe one or two. Vaping is obviously a big topic of conversation at the minute. It's really, really difficult because on one hand, we're wanting to promote vaping as a tool to quit smoking, because although there's not conclusive evidence around the long-term impacts, we know at the moment that it's safer than smoking. So if you can go from smoking to vaping to then nothing, it's better than smoking. But what we also know is that if you've never smoked, you should not pick up a vape, because vapes aren't harmless. They do cause some health impacts, but less those than cigarettes. So the key message is vape is really good if you want to quit smoking, but if you don't smoke, you shouldn't ever pick up a vape, because it is just a tool to help you quit. It is not just something that we should be doing. Seeing I've got a couple of minutes. So I suppose the ask of any sort of clinician or anyone that comes into contact with anyone who smokes, we talk about this sort of making every contact count. And we say it's 30 seconds to save a life, because actually if you support someone to stop smoking, you will have a significant impact on their life expectancy and the quality of life. So we talk about ask, advise, and act. So the ask is, do you smoke? And documenting that if they smoke, so making sure that that's documented on the records. And then if they do smoke, or you know, you can always ask if someone in the household smokes as well, because obviously passive smoking is still a thing, so you can always link in with that. So if they do smoke, you then can provide very brief advice, and I've got some resources at the end if you want to know more. So NCSET, which is the National Centre for Smoking Cessation, offers free like e-learning for health modules about how to have these conversations. So you kind of, you know, have very brief advice. You sort of say, try and talk about some of the benefits of quitting. And then the third step, which is about acting, is, you know, we have a local service available, and you signpost and you support referral into the service. Even if they're not ready to quit, then you can provide them with the information. If you want to know what is available, MechLink London, if you haven't heard of it, is an amazing resource, and it is kept up to date more often than not. But MechLink London it's categorized by like the kind of issue. So you can see there, I've just done a screenshot. So you've got cost of living, alcohol, drugs, healthy diet. If you click on that, and then you click on what their borough is, it brings up what is available in their borough for that specific thing. So there's a load more, you know, that's got home, fire, safety. There's a load more on that list. And the link is at the end of these slides, which I will send out. But it's a really, really useful resource. It kind of tells you everything that exists. And I've just put some resources here. So like I said, the NCSET has got some free training on how to have these conversations with people, MechLink London, the Stop Smoking London, and then there's just an NHS site as well. Just stop sharing. How do I stop sharing? Sorry. I can't stop sharing. Oh, there we go, stop sharing. I was presenting, yeah. Okay, so
thank you.
Yeah, sorry, it was like there's so much I could talk for the entire day about tobacco. And yeah, like it's such an important thing across every group in society. But yeah, so I had 20 minutes. So hopefully that's given you a little bit of a snapshot about what's going on, because there's a lot going on right now with the new government pledge. I don't know if you saw, but the bill went through Parliament and it got voted really positively, like 380 votes to 50, that they want to raise the legal age of tobacco so that no one who's 14 and under now will ever be able to legally purchase tobacco in their lifetime. So it still has to be signed off in law, but it got an overwhelming positive vote in Parliament a few weeks ago.
That's great, Hannah. Thank you so much for sharing those slides and the information as well. There was a quick comment here just to say that referrals to 1U Haringey suspended at the moment. Only self-referrals are accepted. That was from Cola.
1U Haringey has just recommissioned the GP Federation to run their stop smoking services. So it's just moved from one provider to another. So I suspect that's what the comment was about. It's now the GP Federation run the stop smoking service. If there's an issue, if you email me and I'll put you in contact with the manager just to make sure that there wasn't a fault there.
Great, thank you.
Oh, someone's asking about Champix. So okay, sorry, I know I've run out of time. So Champix has Champix, there's two drugs, there's a few drugs. Champix went off the market in 2001, and it's just being reintroduced. So this in secondary care, we've just had it licensed we've just had it approved by the Joint Formulary Committee to be prescribed off license in secondary care, but not yet in primary care. On tomorrow, I am taking to the Joint Formulary Committee, so they sign off all the medicines, a drug called cytosine, which is supposed to be as good as Champix with less side effects, although it's limited in its use with certain clinical groups. So cytosine might be available for prescription shortly, and we're hoping Champix, hopefully by the end of the year, will be back available.
Great, thank you for that. I will collect any other questions that may pop up, Hannah, and then we can email, but that would be, if that's okay with you. Great, thank you so much.
Thank you for your bits in the comments about all those things. I couldn't see the comments. I thought everyone was just ignoring me. But anyway, thank you so much. Thank you for having me. And yeah, I'm happy to come back anytime.
Thanks, Hannah. Thanks for joining us. Thanks. Bye. Teo, you're here. Hi, Teo.
Hi, good afternoon.
Good afternoon to you. I'll let you introduce yourself. Teo's here with some information about system changes for the cervical screening system. Thanks, Teo.
Thank you. I'll take over from here and I'm going to share my screen. It's on the slideshow. Okay. So good afternoon, everyone. My name is Tayo Ilo, and I'm Senior Implementation and Business Change Manager at NHS England, and I've been supporting the NHS cervical screening program with the new implementation of the cervical screening system. So apologies if a number of colleagues attended the various LMC sessions that we had at the beginning of the year. And I know a number of colleagues were not able to get onto those calls. So the slides I'll be sharing today are very similar to those, to the slides we already shared with the LMC, but I'll be focusing more towards the end on some of the readiness progress around the NCL practices and users, so that all colleagues on the call are aware of the actions that need to be completed and what is expected as well. So what is CSMS? CSMS stands for Cervical Screening Management System, and it's the replacement IT system that is currently used by the NHS cervical screening program called Open Exeter. So once the new CSMS goes live, Open Exeter will not be available for users from day one. So this is not a system that will be running in parallel with each other. With the new system, it's going to deliver like-for-like functionality, but it's a lot easier and safer and smoother to use compared to Open Exeter. It's also bringing together a number of every single provider involved in the patient screening journey so that it makes sure that there is a robust collaborative system that supports a patient screening journey. And part of this for the first time also means that the detained estate users will also be coming on board as well, which makes it easier for colleagues working within the primary care and also for sexual health clinics as well. So how will you be using CSMS? Praxis will be able to do exactly what they can do on Open Exeter, but they will still be able to view the screening record for registered patients. They'll be able to check the P&L list and take action appropriately, and also ensure that processes for deferring and seizing a patient outside of the P&L will remain the same. The biggest benefits to this new system is it's removing the restrictions that a lot of users are having on Open Exeter, because this is now going to become a national system now. which means that if a patient is coming from out of borough or out of locality, as long as you have a legitimate relationship with that patient, you'll still be able to view their screening history based on your appropriate role on your smart card. So how will users be able to access CSMS? At the moment with OpenExeter, it's username and password. With the new CSMS, you definitely need to have a NHS smart card, which I believe most colleagues are familiar with. You also need to have the smart card reader installed on your devices, and also make sure that you have the NHS identity agent and credential management software and compatible internet access. I'll be sharing a copy of these slides later. So this is the URL for the new system, and you can have access to check whether your smart card has been set up correctly. We've been working with ICB IT colleagues as well, so they are aware of what the IT requirements are to support users. And towards the go live time, I think most ICBs will be sending out emails again to colleagues to make sure that all users are aware of what is expected. But as we're approaching a very critical stage in implementation, I'm also using this opportunity to please take ownership of the readiness activities, because I've had a number of colleagues sending me emails saying, I assume my practice manager has already completed this for me. So I'm also using this opportunity to please encourage colleagues to please take ownership of making sure that the user readiness for their accounts is also set up correctly. So with the smart card access, all that is required is to make sure that the RA manager or the practice manager, depending on how it's being managed at practice-led or ICB level, to make sure that users have the appropriate outback permissions on their smart card, and also they've been assigned to the cervical screening work group. If users don't have these two, then they can access the new system. It will just tell you that you don't have access to it. So it's important for users to make sure that they work with their practice managers and ICB RA managers to make sure that they have the right permission and our barcodes put onto their smart cards. So as the system is not yet live, this is just a process where we're just making sure we're supporting all users to make sure that they know what is expected of them. So if at the end of this call, you actually click on the link you put in your smart card and you realize you don't have the right permission, the first thing to do is not to please panic, because we still have enough time before the go live, is to speak to your practice manager or the RA manager, depending on the relationship you have or how it's been managed at ICB level, to support you in terms of assigning the barcodes to your smart card. Various ICBs have different requirements. Some ICBs you have to log a call on the portal. Some ICB there is a form you have to fill out. But whatever the process is at ICB, please make sure that you just follow the process to get the barcode assigned to it. Some ICBs have also given practice managers permission, so practice managers can actually go in and assign users to work group allocation. So again, as it's whatever approach is at practice or ICB-led, just speak to the practice manager first to be able to support you. And if you feel you're still not getting the right support, please send me an email and I'll see what I can do from a national level. Okay. So if you work across multiple practices, you only need to have one ODS code for that practice to be able to access the new system. However, if you're working across multiple practices and there is a need for you to manage the P&L list, then you will need to have the ODS code for every single practice assigned to your smart card. So users just need to be mindful of that, because I keep getting a lot of queries saying, I work at one practice, but I don't manage the P&L list. If you work at multiple practices, you only need just one ODS code, especially if you're a sample taker. You only need one ODS code. You'll still be able to find the patient screening history, as it's now a national system, removing the barriers with OpenExeter. So moving on to that. So how do you check the access? As I mentioned previously, once CSMS goes live, OpenExeter will no longer become available. There is a link which takes you to the olden page. The olden page is a mirror of what the live system will be. You will not be able to do any actions on it, but the only thing you can do is to check your permissions. Once you put in your smart card and you follow the screens, the guidance and everything, it will tell you whether you have the right permissions and what you need to do. What this means is, come day one, once the new CSMS goes live, you are then ready to start using the system, as long as you've completed your training as well. If, for instance, you don't have access to the system or you feel you're not, depending on the error message you get, there are guidance available, and the link is also available on this side in terms of the steps and actions you need to take. Sometimes it could be you don't have the right browser, or you don't have the right permissions, or you don't have the right credential management. It could be any number of things, but whatever the error message you're getting, please follow the guidance. The first step to take is to follow the guidance on the website. And if you feel you're not getting any support, then please send me an email and I'll see what I can do to support the user with their readiness journey. Okay. In terms of the training for CSMS, the first part of the training is actually available now on the new NHS Learning Hub, which is replacing the e-learning for health system. It's a very, very short introductory training, and I believe a number of colleagues have probably completed it or they've seen it already. The second part of the training, however, is going to be very, very comprehensive, and that is what's going to cover more in terms of how to use the system, and it will also have more related to users' role in terms of specific questions that users will probably want to know in terms of using the new system. We are expecting the program to make an important announcement very soon. Once the program makes the announcement regarding the go live date, the second part of the training will also be made available at the same time as well. The reason why the program was holding back of second part was because they didn't want to release the training too soon and the system was not ready to go live. But once the announcement is made, hopefully within the next few weeks, the training will become available as well. While we're still on the comms side of things, there are a lot of engagement and comms that will be coming out either from me or the program very soon. So I understand that it's coming to a busy period as well. So I'm going to please request support from colleagues to just make sure that they're on top of whatever actions we need to do in terms of the preparation for Go Live as well. But I will try as much as possible. I've got a number of colleagues that are also working with me in the London team to make sure that we are available to support users with any queries or support to make sure that come day one of the Go Live, everyone is in a very good position to start using the new system. Okay, so once the second part of the training is released, the full training is expected from end to end to probably take about 2 hours to complete. I know a number of ICBs are planning to have like protected training time for their users. So it could be a suggestion as well for NCL, just to make sure that once the second part of the training is made available, users have protected time within their calendars to be able to complete the training. Communication will be made available again on our website through me and from the program as well, once the Go Live date is released by the program. And so finally, what actions do you need to take before the Go Live? Again, like I said, I'm just going to run through the actions again. Make sure you have an NHS smart card and you have the right credentials on your smart card, permissions and everything. Please visit the access page, click on the link, make sure that you have the appropriate permissions and everything. Everything should be green, green, green when you do the checks. And also make sure you create an account on the Learning Hub. You complete the first part of the training, as it makes it easier for you to get used to the training platform before the second part becomes available. And when the second training becomes available, please also make sure you complete that as well. If you need more information, everything is on the website. We always try to update this at least every other day. And if you haven't already signed up, I'm encouraging all users as well to please sign up to the update page on the programs, because it makes it easier. If there is a break of communication between me and the program, at least you're getting the information when the program releases that information as well, so that there is no delay or break, or you're not hearing it from someone else. You're well informed at the same time when the program releases the comms. So in terms of NCL readiness, currently on OpenExeter, the top table is showing the OpenExeter users that we have across NCL. So currently there are 273 users that I can see from the reports I get from the program. And out of those 273, we know that 186 users have completed the readiness activities, which means that we still have 87 users that haven't completed it. It could be for various reasons. Maybe someone has been on maternity leave, they've been away for training or anything. It could be various reasons. But I'm using this opportunity to please remind colleagues that just in case you're one of those users that still have active OpenExeter account and you haven't prepared or completed readiness activities, please speak to your practice manager or your ICB colleagues to be able to support you to get the readiness activities completed on time. Okay. So the second table at the bottom shows what we currently know for NCL in terms of CSMS activities. So we know across the ICB, we currently have about 999 users that have the CSMS allocation. Yes, there is a bit of oversubscription compared to what we have with OpenExeter, and various reason is because OpenExeter, because of the way it was set up, there were less people using the system. But because this new CSMS is now a role-based access, a lot of colleagues within the ICBs or practices are actually taking ownership to make sure that they have the smart cards and appropriate allocation. We have GPs that are completing it as well. We have practice managers, we have support, we have sample takers. So a number of, depending on the size of the practices, a number of colleagues have actually taken ownership to make sure that they have the smart cards and any allocations they have to do ahead of the go live. The also other information we know is that out of the 999 users that we can currently see that have completed the allocation, only 3 of them, 365 users have actually completed the access check page. So every time you go in to complete your access check, we actually run a report and we can actually tell who has done it and who hasn't done it. And while I'm on that subject, so as I mentioned earlier that there are a lot of comms coming out. Once the program releases the go live date, there will be a number of regional comms coming out from me and my colleagues. One will be to the users that haven't completed the readiness activities to remind them to please go in and complete the checks and the training, because it's important for me to make sure that all users are supported and have completed what is required. And the second one is I'm planning to also write to the remaining 87 users directly to make sure that they complete the readiness actions ahead of the go live as well. Also, because I know the nature of frontline and colleagues move in and out of practices and locality and things like that. So if practice managers or colleagues are aware of new users that have either joined or left, I'm also using this as an opportunity to please remind colleagues to review their setup and make sure that any new user is not left and they're all supported as well, and making sure that they are aware of this program and they have the right permissions and allocations and everything needed as well. And finally, my contact details are available along with Julia, who is the training lead for the program, and she will be able to respond to any training related queries. And I'll close it there. Thank you very much, and we can move into questions. Sorry, I was quite fast about it because of the time. I think I've got 2 minutes left.
Thank you, Tayo. That's really, really helpful. A couple of questions about the going live date, but you've kind of answered that to say it's likely to be quite soon, but you're not sure of the date yet. Is that right?
I'm sure of the date. I can't just release the date. It has to come directly from the program, but it's coming out soon. I think that's probably what I can say.
Great. And oh, there was a hand up, but it's gone back down. I didn't see who it was, but if you want to come in, please do. And I just had another very quick question. Will there be enough time from the release of the going live date to be able to complete part 2? What sort of time do you see given?
The program have allocated at least 5 weeks from when the announcement is made to the go live for users to complete the training. So there will be a 5 weeks period to support users.
Great. And one more question from me. The part 1, Tayo, how long do you think that will take? Part 2 will take 2 hours, you said.
I think end to end between part 1 and 2 will probably take 2 hours. Part 1 from users have completed it. Some people said 15 minutes, some people said 20 minutes. So it hasn't really taken that long.
That's really helpful. Thank you. And it was quite reassuring to hear that the people that are not yet ready, the users that are not ready, you're planning to sort of write to them individually. So that's, and is there some sort of a process if you just don't hear from those users, or like you said, they may be on leave or they may be on sort of, long-term leave? Is there a process of informing the practices that we've not been able to get in touch with this user, for example?
I do share weekly reports with the ICB colleagues as well. And I think one thing that I didn't mention in the report is with NCL, we actually have at least one user in every single practice that have completed the user readiness. So if these users can't, for any reason, unable to complete the training or readiness before they go live, the risk is reduced at the practice level. So at least there will be one person at that practice that should be able to access the system from day one.
Great.
But I'm hoping to reduce that risk further to make sure that at least we're able to reach out and support every single user before that go live. Because what I also don't want is on go live date, I'm also getting a lot of emails and queries, and there's only so much me and my colleagues will be able to keep up with. So if we can reduce that impact as much as possible to make sure that everybody is aware of what is expected, and day one, we're all ready to go, no issues, fingers crossed, everybody has completed the training. It just makes it easier for a very smooth transition and adoption of the new system.
Thank you, Tara. That's really, really helpful. We've gone past 2, so I'll close it there. Thank you so much for joining us today. Thank you all for joining today. Next forum day is 19th of June, Wednesday, 1 o'clock again. But thank you all for joining, and I'll hopefully see you all soon.
Thank you very much.
Thanks. Bye. Bye.